Thank you, Laura, for that kind introduction. My name is Matthew Drake. As Laura mentioned, I spent the last 18 years at the Mayo Clinic, and in January of this year, moved to the Hospital for Special Surgery. At the Mayo Clinic, I'm an adult endocrinologist and have a primary interest in metabolic bone disease. But as part of my practice there, I actually had a joint appointment in hematology, where I ran my own MGUS clinic, and also took care of many patients with multiple myeloma and their bone disease. Hematologists are fantastic physicians. The ones I worked with cared very, very deeply about multiple myeloma, but the skeleton was kind of a side project that wasn't actually necessarily always given the efforts that I thought it deserved. And so we worked sort of closely and collaboratively to really try to help patients with monoclonal gammopathies, everything from MGUS to smoldering to multiple myeloma, and really try to help those patients and their skeletons. So again, thank you for this opportunity to present today, and I look forward to having a few case discussions at the end that I've presented, and obviously happy to answer questions about patients or anything else at the end as well. So with that, I have no relevant financial disclosures, and I'll provide an overview, and then I'll go through sort of some of the data in the literature, including some of our own, and then, as I mentioned, ending with some sort of case discussions. So monoclonal gammopathies result from the clonal proliferation of plasma, which are antibody-producing cells, specifically within the bone marrow. There's really a complete spectrum of disease, spanning all the way from monoclonal gammopathy of undetermined significance, or MGUS, which is considered an asymptomatic condition. This term was actually coined by a colleague of mine at Mayo Clinic named Bob Kyle. Bob's about 95 now, but when he coined this about 45 years ago as a hematologist, he was really thinking of it really from a hematologic perspective, which means patients have a monoclonal protein that's measurable in the blood, but it was really unknown whether it would actually ultimately present to multiple myeloma or it would sort of remain at MGUS or perhaps smoldering multiple myeloma. Proceeding after MGUS is smoldering multiple myeloma, which is kind of an intermediate condition. This used to be sort of a more broad category. As we understand the genetics and the biology of it better, it's sort of shrunk down to be sort of a more narrow definition of smoldering multiple myeloma. And then ultimately multiple myeloma, which is a symptomatic hematologic malignancy, and we'll talk more about that. Multiple myeloma, we're going to start because that's the disease that people sort of associate most strongly with bad skeletal outcomes. Affects about 20,000 people or new cases in the United States each year, and represents about 15% of all hematologic malignancies. The risk for developing multiple myeloma, as with any monoclonal gammopathy, does increase with increasing age. We have learned in medical school that skeletal lesions are a very prominent part of multiple myeloma, and in fact are the presenting symptom in the vast majority, probably 80 or 85% of patients who present with multiple myeloma do so because of some sort of skeletal involvement, very often a vertebral fracture or, for instance, a lytic lesion somewhere in their skeleton. Over the course of the disease, anywhere from 80 to 90% of patients have some form of bone involvement. It involves areas that particularly have a high proportion of bone marrow, such as the spine, the ribs, and the pelvis, femur and humerus. For some reason, there's also a predilection for the skull, which we don't understand necessarily as well. You can see on the right there those sort of pathognomonic punched-out lesions in the skull. The skeletal effects of multiple myeloma can be very severe, severe pain, increased risk for fractures, hypercalcemia. I also use the slide for patients. Obviously, we know what hypercalcemia is, and the risk for nerve compression, particularly in the spine. Importantly, though, patients also have generalized bone loss, and we'll discuss that in more detail, and that's due to an alteration in both osteoclast activity, which is increased, as well as osteoblast activity, which is simultaneously suppressed. This is data from Mayo Clinic from Olmsted County, which looks at this is from Joe Melton and Bob Kyle, my colleagues, which looked at the risk for having a fracture in the time before myeloma was recognized versus patients who are age, sex, and BMI matched, what would be expected. And you can see that the cumulative incidence is markedly increased in those with multiple myeloma. Very similar data has been replicated in a cohort in Sweden as well. So again, particularly around the time of multiple multiple myeloma diagnosis, the risk for fracture is markedly increased. Fractures can occur at any sites. They're most common in the axial skeleton, thoracic and lumbar vertebrae, again, sites where there's a lot of bone marrow, ribs, clavicles, cervical vertebrae that can occur, arm, pelvis, and humerus as well. But again, almost any skeletal site can have a fracture in multiple myeloma. And why does this occur? And I'm going to talk about this a little bit, but not delve into too much detail. But basically, from a conceptual perspective, myeloma cells, which are in the bone marrow, adjacent to the bone, send signals which simultaneously increase the activity of osteoclasts by some factors such as MIP1 alpha or interleukins, also simultaneously send factors to suppress the activity of osteoblasts. So we recognize that osteoclasts and osteoblasts are normally very nicely coupled. So if an osteoclast scoops out some bone, an osteoblast will want to come in and actually fill that in. Unfortunately, in multiple myeloma, this actually process is uncoupled, so that the osteoclasts scoop out more bone, and then unfortunately the osteoblasts are not told to actually fill that in. So people can actually have bone scans and actually have large lytic lesions, and those bone scans specifically can be actually fairly negative, because bone scans typically, or they do recognize osteoblastic activity, which is again suppressed in multiple myeloma. So ultimately, this difference leads to an increase in bone resorption with a net decrease in bone formation, ultimately leading to bone loss. This is both local punched out osteolytic lesions, but also systemic bone loss that occurs due to these circulating cytokines as well. Certainly they're paracrine, but there's also certainly found in the circulation as well. How do we treat patients with myeloma bone disease? Well, there are three medications that are FDA approved for this indication, specifically pamidronate, which was the first medication approved. Typically, the studies were done looking at once monthly therapy. We have since learned the importance of backing off on some of this aggressive therapy to limit the risk for osteonecrosis of the jaw and atypical femoral and metatarsal fractures. So after that, it was zoledronic acid at a dose of 4 milligrams, often provided monthly. Again, now less often. We'll talk about some of that. And then the most recent medication, which I'll spend some time talking about, is denosumab or Xgeva, given a dose of 120 milligrams monthly. And we recognize from the osteoporosis literature some of the challenges that can be associated with denosumab use, and particularly denosumab cessation. Importantly, all three of these medications are highly effective from a skeletal outcomes perspective in patients with multiple myeloma. They decrease bone pain, they decrease hypercalcemia, and they ultimately decrease the risk for fractures. I will say that in general, treatment of the myeloma bone disease is occurring adjacent to or alongside treatment of the myeloma itself. The most successful way of approaching bone health and multiple myeloma long term is really to get rid of or decrease the multiple myeloma, because that way you're going to decrease or lower or limit the number of cytokines that are again affecting the osteoclast and the osteoblast, as I discussed in my previous slide. So you really want to obviously do both, but particularly in the early settings, it can be really important to saturate the skeleton with these medications that really reduce the activity of osteoclasts, so that bone is not being so actively resorbed. I'm just going to differentiate the activity of bisphosphonates versus those of denosumab in the next several slides. So we know that osteoclasts sit down on bone. Bisphosphonate-treated osteoclasts undergo apoptosis, and this ultimately leads to decreased bone resorption. That's highly effective. Denosumab works differently. And the analogy I use for my patients is that in order for an osteoclast to become an osteoclast, it has to go through this entire maturation process. So it's sort of like a bunch of kindergartners coming to school. They go all the way through high school graduation. They graduate with their diploma. They're ready to be functional members of society. And when they see a medication like bisphosphonate, about 2/3 of them just get poisoned. So there's simply not as many of them around. Denosumab works fundamentally differently. In order to be a kindergarten to go to first grade, your teacher has to give you a pass, and denosumab basically hides that pass. And so what happens is, if denosumab is continued to be given, none of those kindergartners can sort of advance. But if that medication is ever not given, then all those kindergartners that are sort of backed up in kindergarten have access to that pass. They go straight to graduation, start very rapidly chewing up the bone, and that can have negative skeletal consequences. So basically bisphosphonates cause osteoclast apoptosis, but denosumab inhibits osteoclasts from being formed in the first place. And what we can see here is that both pamidronate and zoledronate were highly effective and worked very well for reducing osteoclast-mediated bone resorption and multiple myeloma. What we can see here is that around January 2018, there was a manuscript published by Nupa Raj and colleagues. So Nupa is at the MGH, she's a hematologist, and it showed that there was really no difference in the effectiveness of either denosumab versus zoledronic acid for reducing skeletal-related events. Skeletal-related events are considered a composite of fractures, need for surgery, need for radiation therapy, and hypercalcemia. So there's really no difference. But because, or likely because, denosumab can be given so much more easily as a simple injection rather than having to come in for a monthly infusion, this is Medicare population data. Within about a year, close to 40% of the patients with multiple myeloma had transitioned or were being treated with denosumab as opposed to zoledronic acid. And unfortunately, I think this number has only continued to increase since that time. However, this is data from the osteoporosis literature, which unfortunately also seems to be the case in patients with multiple myeloma, which is that while denosumab causes very nice increases in bone mass at the lumbar spine, at the total hip, and at the distal radius, once discontinued, all of that bone is very rapidly lost. So for instance, in this case, it took about 2 years to increase the bone mass of the lumbar spine, total hip, or distal radius, but within 12 months of denosumab discontinuation, all of that bone had been lost. And in multiple myeloma, it's even a little bit more serious than that. These patients are on Xgeva, so a higher dose. But in particular, if these patients in multiple myeloma have recurrent fractures, that's certainly of concern for recurrent disease, whether it is in fact recurrent disease or not, because we know that multiple vertebral compression fractures can occur in patients with denosumab discontinuation. And that's just sort of called out here initially by initial statement by the ECTS, which showed that when denosumab is discontinued, there's very rapid loss of bone mass, and patients have a high risk for developing multiple vertebral compression fractures. So, whereas a patient with osteoporosis, this would be problematic. In my opinion, it's doubly problematic in patients with multiple myeloma, because now you're not sure whether this reflects simply the impact of denosumab discontinuation, or whether in fact it means that the disease, multiple myeloma itself, which causes osteolytic disease, and vertebral compression fractures are again often presenting feature of the disease and commonly occur in recurrence, whether the development of multiple fractures is in fact disease recurrence, or in fact whether it's simply denosumab discontinuation. So it's certainly a challenge and problematic in that situation. So if one is using denosumab therapy in patients with monoclonal gammopathies, specifically in this case multiple myeloma, but even in the earlier conditions, MGUS and smoldering multiple myeloma, because if there is evidence for a fragility fracture or vertebral compression fracture, an osteolytic lesion, that would be concerning for MGUS evolving or smoldering multiple myeloma evolving into multiple myeloma, because that's part of what we call CRAB criteria used to define multiple myeloma. So just to recap here, denosumab does not cause osteoclast apoptosis, as do the bisphosphonates, but prevents pre-osteoclasts from becoming active osteoclasts. Therefore, any treatment with denosumab must be followed by a bisphosphonate. Zoledronic acid can be used. That's probably the best data, but again, the data is unfortunately not very good, either in the osteoporosis or multiple myeloma literature, to reflect, to limit rebound bone resorption, and how best to give the bisphosphonate in terms of timing and dosing is really not clear. We tend to, at Mayo Clinic, when I was, again, head of the endocrine and MGUS and myeloma bone group, we tended to not use much denosumab when possible because of these potential complications. It may be a good option for patients with significant renal dysfunction or with limited life expectancy, Although we now know that with severe renal dysfunction, there is an increased risk for severe hypocalcemia and death. And some of these patients with multiple myeloma ultimately do have severe renal insufficiency when they clog their kidneys with the monoclonal proteins. And so that can be, again, an issue as well. Taking a step back, we're going to talk about some of the precursor conditions to multiple myeloma. So MGUS always precedes multiple myeloma. On average, it has been present for around 15 years prior to diagnosis, which is actually very interesting. That data was actually gleaned from a military study, I think out of Walter Reed, where patients in the military were simply having their blood drawn annually for many, many years. And then they were able to retrospectively identify patients who had ultimately developed multiple myeloma and go back and see when they looked at that stored blood, at what earlier point those patients had an SPEP basically that was positive. And it ranged anywhere from about 2 years up until about 28 years with an average of about 15 years prior to diagnosis. So MGUS itself is a pre-malignant condition. The progression to multiple myeloma, however, is very, very low, so only about 1% per year. And the increase of the risk of having MGUS does increase with age. So about 3%, 2 to 3% of patients around the age of 50, but by the time people are 80, it's closer to 8%. But if you just look at U.S. Census data, there's somewhere around 3.5, maybe 4 million people in the United States who likely have MGUS. And only a fraction of those are likely aware that they have it. Probably 50% or less are aware that they have it. Importantly, bone disease also occurs in MGUS, and this is data, again, from the Olmsted County or Mayo Clinic, which shows that these patients have a much higher risk for having vertebral fractures, any sort of axial fracture, and even femur fractures relative to age, sex, and BMI matched patients. So if there's 2 people living next door, otherwise they're the same in every other way, the patient with MGUS has 6.5 fold higher risk of having any sort of vertebral fracture than would a patient living next door with no MGUS. So the way that I think of this is basically if patients don't have MGUS, their risk is certainly possible, but it's not negligible, but it's there. But once they have MGUS, the risk goes up substantially, but that's nowhere near as high as the risk of having multiple myeloma. So when I first became interested in this, there was really a lot of questions in the literature as to why patients with MGUS might be having a higher risk for fracture. There was not a whole lot known about this. There was some data that showed that bone density testing by DEXA was worse in patients with MGUS. A lot of data showed it was not worse. Some studies had shown that bone turnover markers were increased. Some had shown that they were not changed at all. The question really was, why might this be occurring in patients with MGUS? So as part of that, part of my work at Mayo Clinic, which was a center for MGUS and multiple myeloma, was to really understand why this increased bone disease might be occurring. So the standard for understanding what's actually going on at the tissue level is the bone biopsy, which works very well. But we know about bone biopsies. They're invasive. They require sedation. They're typically obtained from the iliac crest, which is not a site which is actually loaded. And they may not be very useful for longitudinal assessments because the biopsy sites will, by definition, be slightly different. So DEXA likewise has specific limitations. We are, by definition, 3-dimensional. DEXA, by definition, is 2-dimensional, so it doesn't allow us to differentiate between cortical and trabecular bone. It, again, gives a 2-dimensional measure of a 3-dimensional structure and tends to underestimate bone density of smaller bones and overestimate that of larger bones. So when I was beginning this work a little over a decade ago, we had access to high-resolution peripheral quantitative CT, and this has now become a fairly standard research technique. At the time, it was a little more novel, but it allows you to obtain a non-invasive bone biopsy, essentially, and allows for an in vivo assessment of bone geometry, density, and bone microarchitecture at very high resolution, about 61 microns, with the second-generation version. The first generation was closer to, I think, 82, give or take, microns, but still, I mean, quite good when you consider that the resolution of a red blood cell is somewhere around 6 microns. It ultimately allows you to construct microfinite element models of bone strength to derive estimates of fracture risk. So it allows you to obtain cortical bone parameters, and I've just listed some of those here, including thickness, volumetric BMD, cortical area, periosteal and endosteal circumferences. It also allows you to obtain trabecular parameters, including BV over TV, and then trabecular parameters, including number, thickness, separation area, and true volumetric, three-dimensional volumetric BMD. So we undertook a study with Alvin Ung, who is an endocrine fellow with me at the time, where we matched patients who had recently identified MGUS, and they were matched for age, sex, and BMI. So 50 patients with MGUS, 20 women and 30 men. MGUS and multiple myeloma tend to be a male predominant disease with a mean age of about 70. Were matched with 100 control subjects from the Olmsted County area. 1-to-1 or 1-to-2, I'm sorry, matched well for age, sex, and BMI. We looked at standard bone mineral density testing at the radius, spine, and hip, and looked at the distal radius using HRPQCT. And I'll just go through some of that data here. This shows that the patients were very well matched. So patients with MGUS in this category, patients, control subjects here, well matched for age, well matched for height, weight, and BMI. There were really no statistically significant differences between any of the groups here. So what we showed here with control patients shown in this column and MGUS patients shown in this column was that trabecular volumetric BMD was about 10% decreased in patients with MGUS relative to controls. Trabecular, that was volumetric BMD, cortical volumetric BMD was also decreased by about 5%. Patients with MGUS also had thinner cortices and also thinner trabeculae, all of which were statistically significant. So again, these patients who have a non-malignant or pre-malignant condition, the vast majority of whom will never develop multiple myeloma, but have a much higher risk for fractures, seem to have significantly altered cortical and trabecular bone microarchitecture. We also showed that these patients, this is a control subject here versus an MGUS subject here. There was significantly increased cortical porosity. Their cortices, as I mentioned, tended to be thinner, and these wouldn't be large enough to be considered osteolytic lesions. Again, these are showing up just by the HR PQCT, so they wouldn't be considered osteolytic lesions, but they're certainly much more mottled appearance to their cortical bone. And this increased cortical porosity was ultimately associated with an increased risk for bone, with an increased, increased cortical porosity was associated with reduced bone strength. Here's just, I've only shown the apparent modulus, but a change of about 9%. So again, these are fairly modest changes, but the average person has had MGUS for somewhere around 15 years before it's diagnosed. So if this has been going on in the background, the vast majority of patients of whom are older anyway, who are losing bone because they're elderly individuals, this is sort of an added insult that's likely contributing to the skeletal fragility that's shown in the epidemiologic fracture data. What do we know about bone loss in multiple myeloma? So back to that original schematic. Apologize. We know that multiple myeloma is associated with several factors which increase the activity of osteoclasts, such as MIP1 alpha, as well as other factors which suppress the activity of osteoblasts, such as DKK1. Those are well documented in the multiple myeloma literature. The question was, were similar factors also evident in patients with this premalignant condition, MGUS? And what we showed in our data was that in patients with MGUS, their levels of the Wnt pathway inhibitor DKK1 were about twofold higher, and their levels of the osteoclast activating factor MIP1 alpha were about sixfold higher. So certainly, again, even in this premalignant condition, circulating levels of these factors, which can affect both osteoblast and osteoclast cells, were fairly different in patients without MGUS relative to those with MGUS. Well, just to go back, sort of the general bone biology here, this is how bone mass changes over the course of lifespan. Bone mass goes up very nicely until you're in your early 20s, fairly stable until about age 50 in women and men. The vast majority of people who are going to develop MGUS are going to be age greater than 50, and with a preponderance of people even being above the age of 75 or 80. This is a time when women and men are naturally losing bone anyway. So we're already from this age. I'm in this age now myself. We're already losing bone, but this is sort of an additional added insult to those patients who have MGUS as well. So my working hypothesis is that the increased fracture risk that we see in patients with MGUS results from both the normal aging process, as I just showed you, as well as the effects of cytokines such as MIP-1 alpha and DKK1 and perhaps others, which are common to the monoclonal gammopathies and how they affect both the osteoblast and osteoclast cell functions. So with that said, how do I approach the patient? I'm just going to have a few slides here, and then we're going to take a brief break so they can stop recording, and then I'll present a couple patients that I've seen as part of my clinical practice. So the MGUS patient, I believe that patients with MGUS and like a proactive approach is warranted. This could include standard bone mineral density testing by DEXA, recognizing that it's likely to underestimate the risk of the actual bone loss that occurs because it can't differentiate between two-dimensional and three-dimensional cortical and trabecular bone. I certainly counsel patients on falls, give them lifting recommendations, ensure that they have adequate calcium vitamin D intake. And those who have documented osteoporosis by DEXA or history of fragility fracture, height loss, or evidence of kyphosis, I think that medical intervention with an anti-resorptive therapy such as bisphosphonate is definitely warranted. I actually have a very low threshold for treating patients even with osteopenia because I think they're at an increased risk for accelerated bone loss relative to normal aging humans. So in those patients, I think medical therapy to limit bone loss and fracture risk may be appropriate and should be considered carefully. And again, likely have a very low threshold for initiating some sort of therapy. And we'll talk about that a little bit more as we talk about some of the patient examples. Lastly, as one of the last slides before we move on to that section, I'll just say that there has been recently a paper so we talked about MGUS, we talked a little bit about multiple myeloma. There's not too much known about smoldering multiple myeloma and how this could be treated. There was a recent paper that was published in JBMR Plus, which looked at romosozumab, the anti-sclerostin therapy, specifically. Smoldering multiple myeloma is not treated with chemotherapy. It is also considered to be a pre-malignant condition that hasn't yet advanced to multiple myeloma. So again, these patients aren't typically treated from a skeletal perspective, but in this case, they did look at some patients. I think there were 12 or 14 patients in the study with smoldering multiple myeloma, and they treated them with romosozumab, and they did show nice increases in bone mass, not necessarily as significant as you would expect to see in a patient with generalized osteoporosis, where the increases might be up more like 10 to 12%, but certainly better than they were when they started. So I've summarized a lot of this data and my thoughts on this into this perspective piece, which I wrote about a decade ago now in JBMR, in which case I suggested that we no longer consider it to be a condition of undetermined significance, but whether it should be considered a condition of skeletal significance, so MGSS, to more accurately reflect the enhanced skeletal risk inherent, I believe, in this condition, really for all patients. Again, the vast majority of these patients will never progress to multiple myeloma, but I think that they're at a much higher risk for having negative skeletal outcomes.